Hey everyone, I'm Kayla. Today we have Dr. Cheung who's going to break down the PRPs for us. Dr. Cheung.
Okay, thank you, Kayla. So I'm Dr. Cheung, shoulder, hip, knee surgery, and also joint replacement. And I also do a lot of injections. And today I'm going to talk about platelet-rich plasma, which we do a lot of here at NewportCare. I've got a PowerPoint presentation to kind of show you how that works. So we'll go with the first slide. So first of all, what is PRP? So it stands for platelet-rich plasma, and that's basically, so blood is drawing your blood. Your blood has a lot of components in it. There's white blood cells, there's red blood cells, there's all the fluid that's in between all the cells, and there's platelets. So plasma is simply just the part of the blood that doesn't have the red cells. Okay, and the red cells are the ones that carry all your oxygen. You need that to like breathe and like live and stuff. Okay, so when you separate out the red blood cells, then you get the white cells, the platelets, and the plasma. And that plasma contains hundreds of proteins called growth factors, which are very important in the healing of injuries. Okay, so they contain growth factors, cytokines, and other things that form new blood vessels, form new tendons, form scar adhesions. Kind of is responsible for making you heal whenever you injure yourself, when you cut yourself, when you bruise yourself. That's what's important in having you heal. So as you see in the picture, it's kind of a picture of the elements of blood. And there's there's plasma, platelets, red cells, white cells. But we're interested in the plasma that contains all the platelets. Next slide. So platelet-rich plasma is the plasma with many more platelets than what is typically found in blood. And so the concentration of the platelets, and by concentrating them, you get a lot more growth factors in them, and can be up to 5 to 10 times greater than usual. And by concentrating all the healing factors, it's supposed to help induce healing for injuries, and that's why we inject it. All right, so in order to get PRP, you have to draw blood from the patient, and usually we tell patients to hydrate themselves, because if they come in dehydrated, they're going to have really small veins. We can't get the veins, so they get stuck a few times. That's not good. So we usually we tell patients, if they know they're coming for PRP, they come in with drinking a bunch of cups of water. Who does a lot of phlebotomy? Nick or Lisa. So in your experience, it's been usually like in the mornings is a little bit better for the phlebotomy, or does it really matter? I've had like different people tell me.
I feel like it really depends on the person. If somebody comes in after drinking a lot of coffee, I mean they're not very hydrated. But the people that come in, I feel like after like lunch, they've hydrated throughout the day. They've maybe had some water at lunch.
Oh, okay.
They come in, they seem to have better pulls for the blood.
Okay, yeah. So basically, getting
Can I
hydrated.
comment on that one?
Yeah.
For patients that are known to have difficult veins,
Okay.
I like to tell them to hydrate 24 hours prior, because we found that sometimes when they hydrate the day of,
It's still not enough.
it doesn't do much. So 24 hours prior, and when those specific patients that we already know have that issue, 24 hours prior, it's normally not a problem.
So when you tell them to hydrate 24 hours prior, what's like your protocol? Like 5 cups of water, or like what do you tell them?
I tell them to try to do a gallon a day.
A gallon a day?
I really do, yeah.
Okay.
And it
helps.
Yeah, it does
Okay.
help.
It makes a big difference.
And sometimes they will tell you I didn't hydrate enough, and it's the day that you have difficulty. So sometimes I think it does help.
Yeah. Okay. So I guess for the front desk then, if you're scheduling somebody and they know they're getting a PRP, then you can say, hey, look, we recommend that you hydrate yourself really well a day beforehand. Just drink a lot.
A lot of water.
And then that'll help get the stick. But then we've all had experiences where they come in for PRP and they're tough sticks, and we stick them a few times and they kind of go home empty-handed. So that's never good. So we want to make sure they're well hydrated ahead of time. So you got to draw their blood. So we draw the blood from the patients, and then once we draw the blood, we spin them in our centrifuges that we have in each office. We spin it down in the centrifuge to separate out into like different layers. There's a top layer, middle layer, and the bottom layer. The bottom layer is going to be the red blood cells. That's the ones that we don't want, and we discard that bottom layer. And that's about 45% of the blood is the bottom layer. And then the next layer is sort of like the cream. That's like the white blood cells and the platelets. That's a thin middle layer. It's very thin. It's called the buffy coat. And that's really that has the most of the growth factors in the in-between layer, between the red blood cell layer and the top layer. There's that kind of white thin layer, and that's what we want to get. That has the most healing factors in it. And on your slides, you'll see it's called like the platelet-rich plasma, or the buffy coat layer. So that's what they're talking about. And then the top layer called the upper layer, and that's where there's just some of the plasma, and that has a lower concentration of platelets. And that's about 55% of the blood. That top layer is still useful because we can use that for different types of injections. So the buffy coat layer has the most growth factors for tendon injuries, but the top layer of the plasma is actually good for arthritic joints. So it depends on what they're there for. We can extract different layers of the blood to inject it for different pathologies of the knee or the tendons. All right, so next slide. Okay, so once you have the PRP, it's spun down, we've got the different layers, we've got the buffy coat, we've got the plasma layer. What do we actually use it for? So there's been a lot of data on PRP in the past 10 years. Mostly PRP was used for tendon injuries, so Achilles tendonitis, tennis elbow, golfer's elbow, patella tendonitis, basically tendon injuries. That's what the classic indications are for. When patients, call us inquiring about PRP, we tell them that, look, we can inject the tendons with the PRP. It does hurt. In fact, you treat the injection not like a pain injection, but almost like a mini surgery. It's like they're going through a procedure. It's gonna hurt for a couple of days. Don't expect to get the injection and walk out like pain-free. So that's not how it works. This injection is almost like a little surgery. So they have to treat it as such, and the mindset has to be the same thing. So they may need a driver to drive them back from the clinic or something like that, because it does hurt after we inject it. So we inject it right into the tendon and delivers all like the growth factors and all the healing factors into the tendon. But as you can imagine, you're injecting like, I don't know, a few cc's of liquid into the tendon. It does kind of sting and burn, and I usually tell people that if they're working, they should take a few days off work. And then after the injection, I also tell them not to take any anti-inflammatories for a week. So that's Motrin, Aleve, Advil, Celebrex, Duexis. All the anti-inflammatories I will hold off for about a week, because that actually counteracts the effects of the PRP. But you're allowed to take Tylenol. If you're on chronic narcotics already, such as Norco or Percocet or Tramadol, you can still take that. So narcotics are okay, Tylenol is okay, but not any anti-inflammatories. And also we tell people to ice it. That usually helps with the pain as well. So that's the actual injection, and we usually inject it right into the area of the tendon. And then sometimes, we don't do PRP in clinic. We also do it in surgeries. It can also sometimes help improve the healing after a surgery. The most commonly cited surgery is Achilles tendon. So if you're doing an Achilles tendon repair, sometimes you can add PRP to augment the healing of the tendon repair. There's some data to support that. So generally it's for tendon injuries. That's the original use for the PRP. And then as the years progress, they've gotten more fancy with how to isolate and harvest the PRP. And there's now something called leukocyte-rich PRP. So leukocyte-rich PRP is basically concentrating it even more. So you go through a second stage of refinement where you either centrifuge it a second time, or you add some other chemicals to induce it to kind of layer it out a little bit more. And so when you refine it a second time, you get that buffy coat, which has that cream of white cells and platelets. You basically extract that. You can get a more concentrated version of that. And so there's many different manufacturers with different kits to concentrate that a little bit more. But as you see on your slides, you've got the whole blood. So there's got the whole blood. You spin it down in the centrifuge. You get that upper layer, the buffy coat layer, and the blood layer. That's the lower layer, right? And you take that top two layer, the buffy coat and the upper layer. You extract that, and you spit it down a second time and refine it a second time, and you even get a more refinement of your platelet-rich plasma. And once you spin it down and separate a second time, then you take the bottom layer, which is all the concentrated growth factors, and you take that and inject into the tendon. So that's called the leukocyte-rich PRP. Because it's a second layer of refinement, it costs more money to do that. So some patients, if they get the they may have a tendon injury that requires that leukocyte-rich PRP. That would be an added cost to do that. That's why we have 2 tiers of charge for the PRP, if you've noticed at the front desk. The leukocyte-rich layer is going to be because it's more expensive to harvest and refine it, it adds more to the cost. All right, so that's that. So that's that layer. And then, as I mentioned before, the leukocyte-rich layer that we talked about, the second refinement layer, that's usually more for tendon injuries. So tennis elbow, golfer's elbow, patella tendonitis, Achilles tendon. It's been used in the proximal hamstring tears. There's some data to support it, but it's not, the problem with proximal hamstring tears, they're not super common, so there's not enough studies to really show whether it works well or not. I mean, we do it, but the data is still a little bit, it's still a work in progress. So we're still working on that data. And what I can tell you though, in rotator cuffs, because we get so many people with rotator cuff tears, I can tell you that the data for rotator cuffs is not great for PRPs. We don't know why. I don't know if it's because it's that space in the shoulder or just the tendons of the shoulder is that particular composition. But PRP for the shoulder generally is of minimal benefit. It doesn't hurt to do it, but it hasn't been shown to be that great in the shoulder. So that's the one area where I don't really push PRP. They can still do what they want, but I don't really guarantee any, I don't promise them huge results with that. Next slide. Okay, then, so we just talked about the leukocyte-rich PRP. That's where the cream of all the white blood cells is. Now we talk about leukocyte-poor PRP. So leukocyte-poor PRP is the upper layer where it's just mostly plasma without too much of the platelets. And actually that is still very useful for arthritic joints, for like knees and hips. So there were a bunch of studies that looked at PRP for the knees, and they found that actually the leukocyte-poor PRP has the best results in terms of pain relief and satisfaction. And we think it's that way because the leukocyte-poor PRP, that one doesn't have as much of the inflammatory growth factors and cytokines. So like I said, when you inject a tendon, it hurts a lot. Okay, when you inject the leukocyte-poor PRP, it doesn't hurt as much because it's not as inflammatory. So it doesn't hurt as much. They can walk out the same day. Usually it's not so bad, and that is more for pain relief rather than healing. But it'll still be painful though. But so the leukocyte-poor PRP, we use it mostly for knees. That one is only one stage of centrifugation, so it's not as labor intensive, and it doesn't require as much kits to harvest. So definitely in the knee, there's really good data to support that 2 injections of PRP spaced about a week apart can have modest improvements in pain scores up to 6 months. So I tell people, look, you can do 2 injections, space them a week apart, and it can improve your pain for up to 6 months in your knee. That's where most of the data is from. The hip data also shows some good results with PRP. It's still a little bit early. They don't have as much data as the knee, but the hip shows that you can inject it for the hip as well with reasonably good efficacy as well. And this is the leukocyte-poor PRP that doesn't have that second stage of refinement. And as an example on your PowerPoint, you can see the picture of arthritis. So a lot of people ask, well, what exactly is arthritis? Well, arthritis is basically that when the lining in your joints goes bad, it's like the treads on a tire. The treads are wearing out, so now the tires kind of going bald. So in your knee, you should have this, use the blue arrows where there's spaces between the bones on that picture on the left-hand side. You want space between the bones. Okay, that's what it normally looks like. When you lose that space between the bones, you get the bone rubbing on the bone. That's on the right side of your picture, and that's the arthritis. So when people ask, what is arthritis? That's where the lining of the joint gets worn out. You have no more space left, and the bone's rubbing on the bone. So when we inject the PRP into this area, it's not going to reinflate the space. You're not going to have, miraculously cure your arthritis. But what it does is we think it lubricates the knee a little bit. It reduces some of the inflammation, and it helps your knee kind of move better without getting all the grinding and clicking from the arthritis. But on the x-rays, you're still going to have arthritis no matter what we do. Okay, so that's the PRP for the arthritis. Next slide. Oh, future direction. So so what's in the future for PRP? So just to reiterate, PRP is platelet-rich plasma. It does not have any live cells. It's just the harvest. It's just the growth factors from the blood. There's no live cells in it. It is not stem cells. it's not going to regenerate any new cartilage. What it does do, it can help cause the tendons to heal better. It can reduce the inflammation in your joints for arthritis. And in terms of future direction where we go from here, it's sort of a question mark as to whether it's useful for hip bursitis. There are 2 out of 3 randomized controlled trials that showed some benefit, but it's kind of all over the place because the people that did those trials, they weren't using the same protocol to harvest the PRP. So one group harvested one way, another group harvested another way. So it's kind of comparing apples to oranges. It's kind of hard to compare. But so far, it doesn't seem to hurt them. So you can do the PRP on the hip bursa, but it's unclear how much benefit it does. But we think it helps maybe. There are probably other injections of steroids or Toradol that probably has more predictable relief. That's what I would usually do first. But for some reason, they can't have steroids because of diabetes, and the Toradol doesn't work. You could try the PRP and see what happens. Again, the data is still kind of work in progress, but there might be some efficacy with that. And then along the same lines, it's unclear whether for hip bursitis, if you're supposed to use the leukocyte-rich or the leukocyte-poor PRP. Because it's bursitis inflammation, you would think that the leukocyte-poor PRP would maybe be better for that to reduce inflammation. But then again, it may be some tendons tearing, and so maybe you want the leukocyte-rich PRP for that. So basically, we don't really know for sure. The data is still kind of out there. So it's something that I had to discuss with patients, whether they want the leukocyte-rich or leukocyte-poor PRP for the hip bursitis. And then other unknown factors that are still, scientists are still working on. What is the best concentration of leukocytes? We actually don't know. There's been a lot of studies looking at different concentrations of platelets, different concentrations of leukocytes, and there's actually a bell curve. So if for a tendon injury, if you have too little of the leukocytes or the growth factors, it doesn't heal. But then again, if you have too much, if it's too concentrated, then it's too painful and it doesn't work either. So there's a sweet spot of just the right amount of concentration for the tendons and versus for the arthritis. But the scientific community hasn't really figured that sweet spot out yet. So for now, we have an idea, but we don't really know for sure. So it's still a work in progress. So that's one kind of big unanswered question about PRP. And then the other big unanswered question is, which is like the best method to get PRP? So as you guys know, there's many different ways of getting PRP. There's there's different centrifuges. There's many other kits out there from many different vendors. And so right now there's no like head-to-head comparison comparing, vendor A versus vendor B on their kits to see which one works the best because, it's expensive and nobody has the time or the money to actually run that trial. So right now there's no data to say whether brand A versus brand B kit is better. I mean, we all know they all work in labs because when the vendors sell you the kits, they have lab data showing that they've harvested the PRP and it works. But there's never been a head-to-head comparison. So right now we don't know which is like the best brand. Everybody's kind of just getting it, and we inject it, and it seems to work, but there's no consensus on the best brand. It's sort of like Coke and Pepsi, which was the better soft drink. Some people think Coke, some people like Pepsi, right? I mean, I think Pepsi is not that good, but some people like Pepsi. But that's kind of where we're at with the state of PRP for now. I guess that ends the formal part of the PowerPoint presentation. Do you guys have any questions about the PRP from what patients ask when they call or anything else? Or phlebotomy side of things?
Are there other applications that PRP works for besides just the joints?
So joints and tendons. We are not sure whether it works for meniscus tears. We inject them anyway because when you have a meniscus tear, most of the time you have arthritis too. So when people come in with meniscus tears, usually have an arthritis, and so the PRP might help with the arthritic pain. Whether it helps meniscus is still unclear. Like, it won't hurt them to inject the PRP, but there's not a whole lot of data showing whether it helps meniscus heal or not. We know that for meniscus repairs, we use fibrin clots to help induce meniscus healing. So this is along that same line where the growth factors might induce meniscus healing, but right now there's just not a lot of data proving that it works in the meniscus. It probably does, we just can't prove it. But we don't have the proof yet. What other questions you guys have at this time?
What are the risks of getting a PRP?
Oh, the risks. Okay, so it hurts. Okay, so it's especially with when you inject the tendons, leukocyte-rich PRP into the tendons, like Achilles tendon, it always hurts. They're always limping out of the clinic. Like I tell them, look, it's not an injection for pain relief. It's like a mini surgery. You're gonna come out with pain, take off work for a couple of days. It's gonna be sore. It takes a few days to get better. So the main downside is just pain from injecting the tendons. That's for tendons though. But if it's for arthritis of the knee or for hip arthritis, it's actually not that bad at all. It's actually pretty well tolerated. So that usually doesn't hurt as much because it's not there's not as many inflammatory leukocytes for the knee injections. Other than that, it's your own blood. It's your own like, it's your own stuff. It's your own body part. So usually there's not a whole lot of side effect with that other than just injection site related pain. And the infection risk is pretty low. I haven't really had any, actually I haven't any infections from PRP injections, so knock on wood, that will continue. Any other questions about the PRP? Incidentally, I've heard, not just for orthopedics, I've heard like I think Botox, like some of the dermatologists and plastic surgeons are also thinking about PRP for like other applications. Obviously, we're not going to do that here, but there are people asking about PRP for like other like cosmetic things, and that may or may not be something in the future, but we certainly don't have the data to support that now. So if people ask for that, then just say no, we don't do that. But it's possible in the future that they might that might be it's in the investigative stages right now. Any other questions about PRP? Yes.
I have someone who had injured his knee, and right before they closed him up after they operated, they sprayed his blood back like inside the incision before they closed him up. They told him it would promote healing.
Yeah. You can do that to promote healing. It's more to help the tendons heal better. So like I said, in Achilles tendon, there are a lot of studies that have shown that if you inject a PRP into the tendon after repair it, it's supposed to help, induce a little bit more healing. So there's some studies to show that. We do that sometimes, but usually if you're a pretty healthy person, you don't smoke, you have diabetes, usually you'll heal it. It's the people that are sort of have some risk factors. They're diabetic, they have poor wound healing, they smoke, or they have vascular disease, they have peripheral neuropathy or, whatever. Then that's where you kind of want to throw everything you can at it to induce it to heal. But most regular people who are pretty healthy usually may not need the PRP during surgery to help it heal. But again, there's all of that. But there's more that can be studied on that. So we're still waiting for the conferences to come up and discuss that more. Any other questions at this time about PRP?
How long is the process?
To actually inject it?
Yeah, from
okay.
start.
So depends how quickly we can get your blood. So when they come in, so once I've talked to them, evaluated them, that takes like 15 minutes to talk to them, examine it. So once I determine that you're a candidate for PRP, the phlebotomist will draw your blood. Usually it takes about 5 minutes to get the blood if you're a good stick. If you need multiple sticks, it could take a little bit longer, take another like 10-15 minutes. Once we harvest your blood, we usually use a centrifuge for about 10 minutes to spin it if it's the leukocyte poor PRP for the knees. If it's a leukocyte-rich PRP, then you gotta spin it the second time. So then it's a little bit longer. So you're looking about like the prep time is about like 20 minutes to prep it, and then you got dried up. We inject it. The injection doesn't take that long. The injection is maybe about like 5 minutes. And for the tendons, it can be a little bit painful. So just come prepared with like a driver to drive you back home if it's a tendon injection. So all in all, like what, half an hour? What do you think? Like like 5-10 minutes draw, 10 minutes to prep, and then 10 minutes to actually inject. So about an extra half hour to actually like go through that process. Any other questions at this time regarding the PRP? All right, good. Well, I'm sure there's more questions down the road. So, all right, good. Thank you, guys.
Yeah.